All right, so here we are with hypokalemia. There is only hyperkalemia left after this one, and although there are many other electrolytes, these are the ones we are going to see. All right, then we will go for the pH balance of the body, which is also important, and that will be all. Then we'll go to kidney disorders. The kidney is the one, as you see, that controls of all these electrolytes mainly. Okay, with hypokalemia, hypo means under, and kal refers to potassium, and emia refers to the blood. So hypokalemia means lower than normal potassium levels in the blood, generally under 3.5 milliequivalents. Now, the vast majority, around 98% of all the body potassium is intracellular, all right? Is inside the cells, and there is almost nothing outside the cells. In fact, the concentration of potassium inside the cells is about 150 milliequivalents, as you see in the drawing, per liter, whereas outside the cell is only those 4.5 milliequivalents. Keep in mind that these potassium ions carry a charge. So the difference in concentration also leads to a difference in charge, which establishes an overall electrochemical gradient across the cell membrane. And this is called the internal potassium balance. This balance is maintained by the sodium-potassium pump, which pumps 2 potassium ions in for every 3 sodium ions out. This concentration gradient is extremely important for setting the resting membrane potential of excitable cell membranes, which is needed for normal contraction of the smooth, cardiac, and skeletal muscles. The external potassium balance is about the potassium in the diet and the one managed by the kidneys. On a daily basis, the amount of potassium that typically gets taken in usually ranges from 50 to 150 milliequivalents per liter, and this is way higher than the extracellular potassium concentration of 4.5. So your body has to figure out a way to excrete most of what it takes in. Excess potassium is secreted into a renal tubule and excreted in the urine. So in order for there to be too little potassium in the blood, or hypokalemia, there are two possibilities. The first is an external balance shift, most often caused by an increase in potassium excretion in the kidneys, which lowers the level of potassium in the blood. And the second is an internal balanced shift, where potassium moves into the cells from the interstitium and the blood. One potential cause of an internal potassium balance shift is having excess insulin. This is because after a meal, glucose increases in blood, and at the same time insulin is released. Then insulin binds to cells and stimulates the uptake of that glucose. But insulin also increases the activity of the sodium-potassium pump, which pulls potassium into the cells. People with type 1 diabetes don't make enough insulin, and so they have to shoot themselves insulin, meaning that they can make a mistake. So in rare cases, an insulin overdose can cause enough potassium uptake into the cells as to cause hypokalemia. Another cause of an internal potassium balance shift could be an alkalosis. You know what it means, getting more basic. That is raising the pH, right? So in alkalosis, the blood becomes too alkaline, and there is low concentration of hydrogen ions, meaning a higher blood pH. So in order to help compensate for alkalosis, hydrogen ions leave the cell and potassium ions enter the cells and leave the blood, resulting in hypokalemia. Most of the cases, though, have to do with the kidney's ability to regulate what stays in the blood and gets excreted into the urine. First off, potassium is freely filtered from the blood into the urine at the glomerulus. After that, about 67% of that potassium is reabsorbed in the proximal convoluted tubule, and an additional 20% is reabsorbed in the thick and ascending limb. And that makes a total of 87, so it leaves a 30% of the initial amount. And at this point, the distal tubule and collecting ducts of the nephron can either reabsorb or secrete potassium, that 30%, depending on what the body needs. Now, an important hormone that helps regulate potassium is aldosterone. Aldosterone increases the number of sodium channels on the lumen side. In the drawing is in the right, and the sodium-potassium pumps on the basolateral side of the principal cells of the kidney, which is represented in the left side. This allows the sodium to move from the tubule into the cell and then get pumped into the blood by the sodium-potassium pump. As the pumps collectively move more sodium into the blood under the influence of aldosterone, more potassium gets pumped into the cell, because the pump makes two potassiums go in, and this is going to raise the intracellular potassium concentration. Having more intracellular potassium and also having more potassium channels in the lumen side, this promotes the potassium secretion, and you lose potassium. Having said all that, in situations where somebody produces too much aldosterone, like in primary hyperaldosteronism, then there's more potassium secretion by the principal cells, meaning more gets excreted, and that means less potassium is retained, which is hypokalemia. Also, commonly used diuretics increase potassium excretion and can lead to hypokalemia. And another external balance shift causing hypokalemia is increased losses of gastrointestinal secretions, typically due to vomiting and diarrhea. Now, the upper GI tract actually only secretes a small quantity of potassium, so direct losses via vomiting are usually minimal, but the loss of stomach acids leads the body to metabolic alkalosis, which, as we already saw, can lead to hypokalemia. Relative to the upper GI tract, the lower GI tract secretes more potassium, so more gets directly lost in the feces in cases of chronic diarrhea, like from infections, inflammatory bowel disease, as well as the use of laxative drugs. Finally, a very small amount of potassium is also lost in sweat, which could be relevant in the individuals who exercise a lot in hot weather. Alright, so there are all these ways to develop hypokalemia, but what happens when somebody has hypokalemia? Well, remember that the concentrations of potassium inside and outside of cells is really super important for maintaining the resting cell membrane potential and ultimately for allowing a cell to depolarize and a muscle later on to contract, and that includes all muscles. All right, the three types, you know, skeletal, smooth, and cardiac muscles. So with low potassium in the blood, the membrane potential can hyperpolarize and become more negative. This means that these muscle cells become less reactive to a stimulus, or in other words, they need a stronger stimulus. So, as clinical manifestations, diminished contractions of smooth muscles can lead to constipation. Diminished skeletal muscle contractions can lead to muscle weakness, cramps, and flaccid paralysis, which tends to begin in the lower extremities and ascend upwards. Respiratory muscles may also be affected, and this will lead to respiratory depression. And finally, hypokalemia can affect the cardiac muscle contractions, which can lead to cardiac arrhythmias as well as cardiac arrest, which means that hypokalemia may kill you. All right, about diagnosis. Hypokalemia is diagnosed based on the presence of low levels of potassium in blood. All right, so through a blood test, you'll if you find below 3.5 milliequivalents, that's diagnosis of hypokalemia. It is also important to get an electrocardiogram, which typically shows a prolonged QT interval and an appearance of a U wave and atrial and ventricular tachyarrhythmias. Okay, don't worry much about this. Just know that it may affect the heart, and the heart may get in problems and stop. Okay, we will cover all this about the ECG in the heart lectures. All right, in patients with severe hypokalemia, the main goal of treatment is always to normalize the potassium levels. All right, so how will you do that? Well, basically reducing ongoing potassium losses by treating the underlying cause like vomiting or diarrhea, and also using potassium sparing the diuretics if diuretic therapy is required, as well as replenishing potassium stores with supplementation. All right, so it is very important in the case of potassium, especially hypokalemia and hypokalemia, to restore a normal level, because it's very dangerous. And this is all for hypokalemia. Coming next, hyperkalemia. All right, but not this week. We'll leave it for the next week. All right, I think that was enough.